Welcome back to the deep dive. Today, we are undertaking a massive mission.
We really are.
We're taking one of the most foundational and comprehensive chapters in MedSurg Nursing, Chapter 56, from Brunner and Sutterths, and synthesizing everything you need to know about dermatologic disorders.
That chapter is a behemoth, but it's so essential because the skin is, it's our first line of defense.
Exactly. And it's a huge source of patient morbidity.
And often a window into deep systemic health issues. So our goal is to synthesize the core concepts from routine skin integrity and risk assessment tools like, say, the Braden scale.
All the way through to the really specialized treatment of skin cancers and severe blistering diseases.
Right.
Essentially, we're trying to give you the clinical framework you need to navigate dermatologic nursing.
And before we dive in, we should probably establish some of the essential language.
Good idea. Because understanding the mechanism is half the battle.
Agreed. Let's start with a term that's central to understanding autoimmune skin disease, acantholysis. This isn't just a rash. It's the physical separation of epidermal cells from one another.
Ah, so the glue holding them together is failing.
Precisely. It's caused by damage to those intracellular substances, and that cell separation is what leads to those fragile, easily ruptured blisters we'll discuss later on.
And then there's pruritus, which is, simply the medical term for itching.
But it's never simple in practice, is it?
Never. Pruritus can indicate everything from dry skin to kidney failure.
Right. And in wound care, you will constantly hear the term SLU.
All the time.
This is that soft, moist, avascular, non-perfused, devitalized tissue.
And it can be any color, really. White, yellow, tan.
Even green or gray. And we care so much about it because a wound covered in SLU just cannot heal.
It's dead tissue.
It's dead tissue, and it blocks epithelialization. So its presence is a non-negotiable indicator that you need to debride.
Okay, last one. Let's differentiate two common infections. A furuncle.
A boil. It's an infection of a single or maybe a few hair follicles.
And a carbuncle.
That's the bigger, scarier cousin. It's an extension of that infection, but it involves multiple hair follicles.
Creating a much larger, deep-seated abscess.
And that size difference is what dictates the urgency and the systemic risk.
All right, let's start where all good dermatologic care should start.
Prevention.
Exactly. And this comes down to routine skin protection and, surprisingly to some, maintaining the right pH balance.
This is a huge, often overlooked point.
It really is. The skin needs to maintain its natural, slightly acidic pH. It's around 5.5 because that's its protective acid mantle.
And when we use those traditional, cheap alkaline soaps, we just strip that barrier away.
Leaving the skin vulnerable to drying, irritation, and opportunistic bacteria. That's why alkaline soaps must be avoided.
The literature is clear on this. You want no rinse, pH-balanced soaps, especially in acute care settings.
Okay, so what about managing dry skin or xerosis?
So for this, nurses really need to be product scientists. We use two main types of moisturizers.
Right.
First, you have emollients. Their main job is to lubricate and soften the skin itself.
And the other type?
Are humectants. These are ingredients designed to attract water from the environment, or even from deeper skin layers, to the surface.
So they're perfect for that really intensely dry, flaky skin.
Exactly.
So the basic bathing protocol is simple, but adherence is everything.
It is. You use mild, lipid-free soap substitutes, think brands like Cetaphil or Cerave.
And you rinse completely.
And most importantly, you blot the skin dry. That vigorous rubbing creates friction and tears that delicate top layer.
A crucial teaching point there. And even the laundry product should be fragrance-free to avoid triggering contact dermatitis.
Absolutely. Now, moving from routine care to lesion management, preventing secondary infection is just non-negotiable.
Every single skin lesion is a potential portal for infection.
So that demands strict adherence to standard precautions. Anytime you're inspecting a lesion, especially one with purulent drainage or doing a dressing change,
Gloves are mandatory.
mandatory. And that includes following all OSHA regulations for PPE and how you dispose of contaminated dressings.
That leads us to a critical topic. Pharmacologic delivery vehicles.
Oh, yes.
When a doctor orders a steroid or an antifungal, the format lotion, cream, gel, ointment is just as important as the drug itself.
It is, because the vehicle dictates absorption and contact time.
And the fundamental rule here is wet wounds get drying agents. Dry wounds get lubricating agents.
That's the mantra. So if you have a weeping acute rash, you want something that dries it out, like a lotion suspension. Think calamine.
It evaporates quickly and leaves a medicinal powder layer behind.
Exactly. Conversely, if you have a chronic, dry, scaly patch, you need an ointment.
Because they're oil-based.
Right. They retard water loss, lubricate, and protect, making them the superior choice for chronic conditions like eczema or psoriasis.
So where do creams fit in all this?
Creams are emulsions, either oil and water or water and oil. If you want something that's cosmetically acceptable, you go for oil and water. It absorbs quickly but can be drying.
But if the goal is heavy-duty moisturizing for dry, flaking skin?
Then you choose the greasier water and oil emulsion. The key takeaway for you listening is don't just grab a cream. You have to know its base.
Okay, so we have to discuss topical corticosteroids. They're the backbone of treating inflammatory dermatosis.
Incredibly effective, but potency matters immensely.
It does. And this is where we need to go beyond the obvious risks. We all know not to use high-potency steroids on the face or in skin folds, right?
The groin, the armpits.
Yeah. Absorption is highly enhanced there, leading to risks like steroid-induced acne or hypertrichosis.
But the critical systemic risk, especially when you're using high-potency steroids over a large surface area or under an occlusive dressing for a long time.
Is adrenal suppression.
Exactly.
Yeah.
The body absorbs that exogenous steroid, and it signals the adrenal glands to stop producing their own cortisol.
And that is a life-threatening systemic side effect. It requires careful patient education and sticking to strict limits, often no more than 4 weeks for those high-potency preparations.
We also use intralesional therapy, right? Injecting a sterile suspension, usually corticosteroid, directly into the lesion.
Which is fantastic for tough fibrotic lesions like keloids or cystic acne.
It is. The nursing caution here is all about the injection depth. If you inject too deeply, you risk local tissue atrophy and permanent discoloration.
Let's shift to modern wound care. The chapter outlines the 5 rules of wound care, and this really revolutionizes how we choose dressings.
It moves us away from just grabbing generic gauze for everything.
Rule 1 is categorization. Nurses have to know the generic categories: alginates, hydrogels, foams, and what they do.
Their functions, indications, contraindications. Rule 2 is selection. Choose the safest, most effective, easiest to use, and most cost-effective option.
I love Rule 3. Change. Dressings are changed based on assessment, not the clock.
Such a key point. If a dressing is doing its job and the wound environment is stable, you leave it alone.
Rule 4 is evolution. This is a great clinical reminder.
Chronic wounds rarely use the same dressing throughout the entire healing process. You have to evolve the protocol as the wound changes.
Like switching from an absorbent foam to a hydrating hydrogel once the exudate decreases.
Exactly. And Rule 5, a critical safety mandate, is practice. Dressing changes require professional assessment and clinical judgment.
So they should never be delegated to unlicensed personnel.
Never.
Okay, let's quickly walk through the dressing functions. If you have a highly exudating wound, you need maximum absorption.
So you're reaching for alginates, which are made from seaweed and are amazing absorbers, or foams.
And if the goal is managing the bioburden, the bacterial load.
You're looking for antimicrobial dressings, typically those impregnated with silver or iodine.
Then you have debridement-removing non-viable tissue. We've got 3 types.
Autolytic debridement is the gentlest. You cover the wound with an occlusive dressing like a transparent film or a hydrogel.
And you let the body's own moisture and enzymes do the work of dissolving the slew.
Then there's chemical or enzymatic debridement, which involves applying topical agents, usually collagenase, that actively break down necrotic tissue.
And here's a critical alert.
Yes. If you're using enzymatic agents like collagenase, you must avoid using silver or iodine antimicrobial dressings at the same time.
Why is that?
They'll inactivate the enzymes. You'll be canceling out your treatment.
Wow. Okay. And finally, we use dressings for hydration and protection.
Right, like hydrogels or transparent films, which maintain that essential moist environment needed for optimal healing and cell migration. Now we move to arguably the highest risk, highest cost clinical problem in acute care: pressure injuries.
Or PIs, formerly known as pressure ulcers. A PI is localized damage caused by pressure that exceeds the normal capillary closure pressure.
Which is roughly 32 millimeters of mercury. Once you pass that threshold, the tissue becomes ischemic and then anoxic.
And that results in cell death.
The clinical scope is just staggering. We're talking 2.5 million acute care patients affected annually in the U.S.
And the cost is immense, up to $70,000 to treat a single full-thickness injury.
That financial burden really underscores why prevention isn't just a clinical goal, it's an economic mandate.
So to prevent them, we have to assess the risk, and the standard tool here is the Braden scale.
The Braden scale uses 6 subscales to quantify that risk: sensory perception, moisture, activity, mobility, nutrition, and friction and shear.
A score of 18 or lower means increased risk.
Right. And when we assess, we're looking for things like advanced age, comorbidities like diabetes and stroke, incontinence, and malnutrition,
And in the labs, we're monitoring for a low serum albumin below 3 grams per deciliter or low prealbumin.
which is a faster, more sensitive indicator of nutritional status and protein deficit.
Let's focus on the mechanical forces because this is where the deepest injuries often begin. We have to strictly differentiate friction and shear.
Yes, friction is just rubbing skin against the surface like dragging a patient up in bed, or vigorous toweling.
But shear is much more damaging to deep tissue. This is a parallel force.
It happens when a patient slides down in bed. Their skeleton moves, but their skin stays stuck to the sheets.
So it stretches and twists the deep blood vessels, disrupting that microcirculation.
And that often leads to deep tissue injury and tunneling or sinus tracts that are breeding grounds for abscesses.
So when you look at the Braden scale, while moisture is important, the mobility and friction shear subscales are often the biggest drivers of the most severe injuries.
Specifically, deep tissue pressure injuries, because they target that bone-muscle interface.
And the role of moisture just amplifies this risk. Prolonged contact with urine, stool, or sweat causes maceration.
It softens the skin, making it highly vulnerable to friction and bacterial invasion, which increases the risk of sepsis.
Okay, let's detail the staging using the MPIAP criteria. This has to guide our treatment. We'll start with the one that often reveals the damage underneath. Deep tissue pressure injury, DTPI.
A DTPI presents as a persistent, non-blanchable, deep red, maroon, or purple discoloration.
The skin can be intact or not, and this is critical because that discoloration suggests intense pressure or shear at the bone-muscle interface.
And it can evolve rapidly over a few days to reveal a much higher stage of injury underneath.
So stage 1 is non-blanchable erythema of intact skin. You press on it, it stays red.
Importantly, stage 1 discoloration does not include purple or maroon. If you see that, you have to suspect DTPI.
Right. Stage 2 is partial thickness skin loss with exposed dermis. The wound bed is viable, pink or red, and moist.
It might look like a ruptured serum-filled blister. And crucially, in stage 2, you never see adipose tissue, slough, or eschar.
Okay, stage 3 is full thickness skin loss. This is where adipose or fat becomes visible.
You'll often see granulation tissue and epibole, those rolled, thickened wound edges, and you might find undermining and tunneling.
But the key delimiter is muscle, tendon, or bone are not exposed.
Correct. Stage 4 is the most severe full-thickness skin and tissue loss. This is characterized by exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone.
And finally, the unstageable injuries, where the depth of the damage is completely obscured by slough or eschar.
And here's the crucial clinical caveat. Stable, dry, adherent eschar on the heel of an ischemic limb should generally not be removed.
Why not?
Because it's acting as the body's natural sterile dressing. Removing it risks introducing infection into a poorly perfused area.
Okay, moving to interventions. Prevention is always centered on relieving pressure.
And position changes are paramount. The number one rule for keeping pressure off the sacrum is elevating the head of the bed no more than 30 degrees.
Any higher than that. And you drastically increase the shearing forces as the patient slides down.
We also use the bridging technique with pillows positioning patients in a 30-degree side-lying position, supporting them above and below the sacrum.
To make sure the greater trochanter and other bony areas are offloaded.
Exactly. And for patients with sensation loss, this regimen needs to be meticulous, every 2 hours or even more often.
We also rely on pressure redistribution surfaces.
For immobile or high-risk patients, dynamic devices like low air loss beds or oscillating beds are essential because they constantly change the pressure points.
And nutrition is the fuel for healing. We have to ensure adequate protein intake to maintain a positive nitrogen balance.
We monitor prealbumin weekly. And remember, carbohydrates are vital as they spare protein for tissue repair.
And specifically, vitamin C, ascorbic acid, is the cofactor needed for collagen formation.
When moving patients, especially those at high risk for PI, we have to use mechanical lifts or enough people to lift, not drag.
For minimize friction and shear.
Yes. And for moisture management, use a barrier. After meticulous hygiene, apply a topical barrier ointment like petroleum jelly for patients with incontinence. It creates a water-repellent seal.
In treating established injuries, stages 3 and 4 always require debridement.
We use both high-tech and low-tech methods. The VAC device, or vacuum-assisted closure, is critical here.
How does that work?
It applies negative pressure to the wound bed through a specialized sponge. This reduces edema, increases blood flow, removes excess fluid, and stimulates granulation tissue.
We also have hyperbaric oxygen therapy, or HBOT.
Right, where the patient is in a chamber breathing 100% oxygen at increased atmospheric pressure. This massively increases oxygen delivery to hypoxic tissues.
And it's often reserved for complex, non-healing wounds like diabetic foot ulcers.
It is. For long-term prevention, especially in spinal cord injury patients, we have to teach them to gradually increase their pressure tolerance time.
Starting at maybe 5 to 15-minute increments.
Exactly. Along with a lifelong mobility regimen. Because these injuries have a huge rate of recurrence.
Let's transition from the mechanics of pressure to the symptom of discomfort, pruritus.
Or itching. While it's often localized, persistent or generalized itching must always be investigated.
Because it's a common first sign of internal systemic disease.
This is a massive diagnostic clue. If a patient comes in with generalized itching with no obvious dermatologic cause, the nurse has to flag this.
It could be diabetes, blood disorders.
Kidney or hepatic diseases, or even an occult malignancy like lymphoma, breast, or colon cancer.
And medications are major triggers too. Opioids, aspirin, antibiotics.
The physiological problem is that itch-scratch cycle. Scratching releases inflammatory mediators, primarily histamine.
Which just generates more intense itching, perpetuating the cycle.
So management focuses on breaking that chemical and mechanical loop. Non-pharmacologic management is key. Avoid hot water and traditional soaps.
Because hot water causes vasodilation and intensifies the itch.
Right. Use bath oils, tepid water, and apply cool compresses to vasoconstrict and soothe.
Pharmacologically, for localized relief, we can use topical anesthetics like lidocaine.
But for generalized, especially nocturnal pruritus, we rely heavily on oral sedating antihistamines like hydroxyzine or diphenhydramine.
And the sedation is the point, right?
It is. It interrupts the central perception of the itch, which allows the patient to sleep. The non-sedating agents are generally ineffective for widespread pruritus.
Interestingly, for itching that's secondary to chronic liver disease or kidney failure.
SSRIs like fluoxetine or sertraline can sometimes help. They seem to modulate the central perception of the itch where traditional antihistamines fail.
So the nursing teaching is blot dry, lubricate immediately after bathing while the skin is still damp to trap moisture.
And strictly avoid vasodilating triggers, alcohol, hot foods, overly warm rooms, which bring more blood to the skin and intensify the sensation.
Moving on to secretory disorders, let's start with hidradenitis suppurativa.
This is a chronic, really painful condition affecting the axillary, genital, and perianal areas.
Pathophysiologically, it's now understood as a disorder of follicular occlusion.
The hair follicle gets plugged. That leads to inflammation, infection, abscesses, and eventually deep-seated sinuses and severe hypertrophic scarring.
And it's more common in smokers, obese patients, and those of African descent.
The manifestations are these painful, firm, pea-sized nodules that eventually rupture and drain purulent material.
They tend to coalesce, forming bridges or deep tracks.
Yeah. Management involves aggressive hygiene, warm compresses, long-term oral antibiotics, and often requires surgical excision or CO2 laser surgery to remove that scarred tissue.
The other secretory disorder is seborrheic dermatitis.
A chronic inflammatory disease linked to excessive sebum production, or seborrhea. It's common in those highly sebaceous areas, like the scalp, face, and skin folds.
And we see it in two forms, right?
The oily form, which is greasy and slightly red, and the dry form, which we all know as dandruff.
Management is centered on control, since it's a chronic disorder.
For the scalp, control involves frequent shampooing, at least 3 times a week, and the strategic rotation of shampoos.
So you rotate products with selenium sulfide, zinc pyrithione, salicylic acid, or tar.
Exactly, to prevent the overgrowth of causative yeasts and prevent resistance. For facial inflammation, a low-potency topical corticosteroid can be used, but with extreme caution near the eyes.
Why is that?
Because of the risk of inducing glaucoma or cataracts. Next up is acne vulgaris, the most common dermatosis globally. We have to understand the precise pathophysiology to treat it right.
It's a chain reaction. Male hormones, or androgens, stimulate the sebaceous glands, leading to massive sebum production.
This sebum then combines with hyperkeratinization, the excessive buildup of dead skin cells, to create a blockage.
A sebum plug, called a comedone. And once it's plugged, the follicle gets inflamed.
Clinically, we classify the lesions. Closed comedones are whiteheads, where the plug is trapped under the skin.
And open comedones are blackheads. That dark color isn't dirt.
No, it's oxidized lipid, bacteria, and epithelial debris. Deeper inflammation leads to papules and pustules, and in severe cases, cysts and nodules.
So the medical management goals are extensive. Reduce bacteria, decrease sebaceous activity, prevent plugging, and ultimately minimize scarring.
And while hygiene is necessary, it can't cure acne. Patients should wash twice daily with a cleansing soap and use oil-free cosmetics.
What about diet?
Well, the evidence now does suggest a correlation between acne severity and foods high in refined sugar, so minimizing those is a sound recommendation.
For mild acne, the first therapy is topical.
Right. Benzoyl peroxide is excellent. It's antibacterial, depresses sebum, and helps break down comedones.
But it often causes redness and scaling at first, which has to be part of your patient teaching.
Or you can use topical retinoids to regulate cell turnover. For moderate to severe acne, we jump to combination therapy.
So that's combining a topical agent with an oral antibiotic like minocycline or doxycycline.
And crucially, these antibiotics are used short-term, 3 to 6 months, to avoid fostering bacterial resistance, which is a major concern.
Then there's the most potent systemic medication, the retinoid isotretinoin.
Reserved for severe cystic acne that hasn't responded to other treatments. This drug is a game changer for many patients, but the risk profile is immense,
It is highly teratogenic. It causes severe birth defects.
which requires strict adherence to risk mitigation programs, the REMIS program in the U.S., mandating monthly negative pregnancy tests, and 2 forms of effective contraception for women who can become pregnant,
And we also have to monitor for side effects like severe dry lips, dry mucous membranes, and the rare but serious risk of depression and suicide.
which requires robust psychological support.
There's also phototherapy.
Blue light, specifically 407 to 420 nanometers, is absorbed by porphyrins produced by the P. acnes bacteria, and it destroys the bacterial cell membrane without damaging surrounding tissue.
Okay, so nursing management here really hinges on preventing scarring.
And the first and most vital rule is avoid manipulating the lesions,
No picking, no squeezing, no rubbing.
because squeezing just pushes the follicular contents deeper into the dermis, causing it to rupture and significantly increasing the chance of permanent disfiguring scars.
We also need to provide emotional support. Acne often leads to anxiety and body image issues.
Right. Providing positive reassurance and reinforcing that they're on the correct, often complex regimen is just as important as the medication itself.
And teach them to avoid external friction, like from tight collars or just habitually resting their hand on their cheek.
Okay, let's look at pyodermis, or bacterial infections, starting with impetigo.
This is a highly contagious bacterial infection, usually staph or strep, very common in children.
The clinical presentation is unmistakable. It begins as a red macule, becomes a vesicle that ruptures, and then it's covered by a characteristic, loosely adherent honey yellow crust.
And the nurse has to first soak or wash off those crusts before applying topical antibacterial therapy, like mupirocin.
Right, to allow the medication to actually reach the bacteria.
If the infection is widespread, systemic antibiotics are necessary, especially if it's streptococcal, to prevent that non-cutaneous, life-threatening complication of acute glomerulonephritis.
Education here is critical. Daily bactericidal bathing, strict hand hygiene, separate towels until the lesions are healed.
Next, we revisit the hair follicle infections, furuncles and carbuncles.
A furuncle, or boil, is a deep folliculitis that progresses to cellulitis and eventually points.
And a carbuncle is that deep-seated abscess involving several follicles, often on the neck or back, and it's associated with systemic symptoms like high fever and a high white count.
It poses a high risk of sepsis. The clinical mandate is strict: never squeeze, pick, or manipulate these lesions.
You use warm, moist compresses to hasten localization and pus formation, making them ready for IND by a practitioner.
And this leads to a crucial safety alert about the anatomy of the face.
The triangle of danger.
Exactly. The area from the corner of the mouth up to the eyes drains venous blood directly into the cranial venous sinuses.
So manipulating a boil in this specific area can force bacteria into the sinus system.
And risk life-threatening complications like sinus thrombosis or a brain abscess.
Long-term prevention focuses on decolonization.
Right. Since these are often staphylococcal, patients and their families may need to use antibacterial soap and shampoo for several months and thoroughly launder everything to eliminate the pathogen from their environment.
Okay, shifting to viral. Herpes zoster or shingles.
This is a reactivation of the varicella zoster virus from the dorsal root ganglia, usually because of age-related waning cellular immunity.
And it proceeds through 3 distinct phases.
First, the pre-eruptive phase, which can be 1 to 10 days. It's characterized by pain, itching, or paresthesias along a single dermatome. often before any rag appears,
So it can be misdiagnosed as heart pain or nerve pain?
easily. Second is the acute eruptive phase, where that painful unilateral rash appears as vesicles that crust over. The pain is typically severe and unrelenting.
And the third case is the dreaded postherpetic neuralgia.
That persistent, localized pain that can last for months or even years. It affects about half of older adults who get shingles.
Management has to start fast. Oral antivirals like acyclovir or valacyclovir, given within 72 hours of symptom onset, are necessary to limit the severity and duration.
And pain control is paramount, moving from NSAIDs or opioids acutely to gabapentin or pregabalin for that neuralgia phase.
For prevention, the current guideline strongly recommends the non-live recombinant zoster vaccine, RZV.
Yes, over the older live vaccine for all adults 50 and older, regardless of whether they've had the disease or the previous vaccine. It's a highly effective two-dose regimen.
We should also briefly mention a surprising viral finding from the recent past.
The dermatologic manifestations of COVID-19.
The most notable sign was perneal-like acral lesions, quickly nicknamed COVID toes.
These are areas of edema and erythema, mostly on the fingers and toes. They look like chilblains, but they're not related to cold exposure.
And they were particularly common in children and young adults.
And critically, they often represented the sole manifestation of a SARS-CoV-2 infection. The nursing implication is clear. Any patient presenting with unexplained acral lesions has to be tested for COVID-19.
Let's move to fungal infections, or tinea, also known as ringworm.
Extremely common. We classify them by location. Tinea capitis on the head, corpus on the body, curris in the groin or jock itch.
Pedis on the feet, athlete's foot, and unguium in the nails, which is on onychomycosis.
Diagnosis relies on scraping scales from the margin and examining them with a potassium hydroxide or KOH prep under the microscope.
And for tinea capitis, you can use a Wood's light to look for fluorescence.
Treatment really depends on the depth of the infection. For most body tinea, topical antifungals are enough.
But for deep infections like tinea unguium or nail fungus,
The keratinized nature of the nail requires prolonged systemic therapy, often 12 weeks of oral antifungals, along with careful patient teaching to prevent reinfection from old shoes.
patient education is vital for preventing spread and recurrence for tinea crus.
Patients have to avoid tight clothing and thoroughly pat not rub the skin folds dry. Use separate towels for the affected area and launder them frequently.
All right, finally, let's address parasitic infestations, lice, pediculosis, and the mite, scabies.
Lice are ectoparasites that feed on human blood, causing intense itching. We categorize them into head, body, and pubic lice.
Head lice are easily identified by the nits, those silvery, glistening oval bodies firmly cemented to the hair shaft close to the scalp.
Body lice live primarily in the seams of clothing, and pubic lice are often sexually transmitted.
Management focuses on two things,
Sure.
killing the parasites and removing the nits.
Shampoos containing pyrethrin or permethrin are the mainstay. After you apply it, a fine-toothed comb dipped in vinegar helps loosen the nits.
And for body lice, washing clothes and bedding in hot water at least 130 degrees SRAS is often enough since the lice don't live on the host.
And the key teaching point is to dispel the myth. Lice infest anyone. It is not a sign of uncleanliness.
And because they're so contagious, all family and sexual contacts have to be treated at the same time.
Now, scabies is an infestation by the mite Sarcoptes scabii, which burrows into the top layer of skin.
Common sites are those intertriginous areas, between the fingers, on the elbows, and buttocks.
And the clinical hallmark is the burrow, a minute wavy brown or black line.
And we have a critical gerontologic consideration with scabies.
We do. Older adults may have a diminished inflammatory and sensory response, which leads to a massive, non-pruritic presentation called crusted scabies.
And it's highly contagious because of the sheer number of mites.
Staff must wear gloves and use isolation precautions until the diagnosis is confirmed.
Diagnosis is confirmed by scraping the superficial epidermis to visualize the mite or its byproducts.
Treatment involves a warm, soapy bath, followed by the application of 5% permethrin cream, applied thinly from the neck down, left on for 12 to 24 hours, and then repeated 1 week later.
And just like with lice, all contacts must be treated concurrently, and all clothing and bedding has to be washed in hot water.
Shifting away from infectious agents, let's examine common non-infectious inflammatory skin diseases.
Starting with irritant contact dermatitis, ICD. This is a non-allergic reaction to chemicals or physical irritants like soaps and detergents.
This is an unfortunately common occupational hazard, especially for healthcare workers who are constantly washing their hands.
Symptoms range from itching and burning to full-blown erythema, edema, and weeping vesicles.
And chronic scratching leads to that thickened skin or lichenification. The primary treatment is complete removal of the offending agent and skin barrier protection.
Using creams with dimethicone or ceramide.
Right. The recent COVID-19 pandemic highlighted this risk perfectly. Studies reported ICD prevalence of up to 97% among frontline HCWs.
Because of the prolonged wear of occlusive PPE like N95s and goggles and all the compulsive hand hygiene.
The American Academy of Dermatology gave specific advice. Use high petrolatum moisturizers after hand hygiene.
And if an N95 is causing breakdown, use a liquid skin sealant underneath the mask.
Right, because petrolatum can interfere with the seal. Off work, they need to keep the skin clean, dry, and well moisturized.
And patient education stresses avoiding heat, soap, and fragrances. If using gloves for chores, wear cotton-lined gloves and limit wear time to 15-20 minutes to prevent maceration.
And next is psoriasis, a chronic inflammatory multisystem autoimmune disorder.
It affects the skin, the joints, and sometimes other organs.
The pathophysiology is driven by activated T cells and inflammatory cytokines infiltrating the epidermis. This triggers incredibly rapid epidermal cell turnover,
Cells mature in days instead of weeks.
resulting in that classic presentation: red, raised patches covered with distinctive profuse silvery scales.
And while we often see it as just a skin disease, up to 42% of patients develop psoriatic arthritis.
An asymmetric, rheumatoid factor-negative arthritis. Triggers include stress, trauma, and infection.
Since there's no cure, the goal is control. Management starts with gentle scale removal using baths with oil or colloidal oatmeal.
Yeah. Topical corticosteroids are the primary tool, but we return to the warning: limit high-potency use.
Especially because occlusive dressings, which increase steroid absorption, must be removed for 8 hours a day to prevent the risk of adrenal suppression.
For moderate to severe disease, systemic agents are necessary. Methotrexate is frequently first line. It's a cytotoxic drug that slows epidermal turnover.
But it requires careful monitoring for severe liver, kidney, and bone marrow toxicity, and it is teratogenic.
Cyclosporine, a powerful immunosuppressant, is reserved for short-term use due to risks of hypertension and nephrotoxicity.
And the modern approach uses biologic agents.
These are targeted therapies, essentially designer drugs. They specifically inhibit the inflammatory cytokines or the T cells driving the proliferation.
They offer better control, but require close monitoring for serious side effects, including an increased risk of infection.
So nursing management has to address the significant psychological component, the despair and frustration.
You have to reassure the patient that the condition is not infectious or related to poor hygiene.
And emphasize strict adherence to often complex regimens and avoiding trauma, which can trigger new lesions.
Finally, we have to address a life-threatening condition: generalized exfoliative dermatitis, or erythroderma.
This involves scaling and erythema covering over 90% of the body surface.
It's a medical emergency, often secondary to a drug allergy or an underlying disease exacerbation, like severe psoriasis.
The pathophysiology creates a profound systemic crisis. The widespread loss of the stratum corneum barrier causes massive capillary leakage, hypoalbuminemia,
And critically, widespread cutaneous vessel dilation.
which leads to massive body heat loss. Patients experience severe chills, fever, and impaired thermoregulation. The nursing priority here is preventing sepsis, which is the leading cause of death.
These patients require hospitalization, IV fluid management, and a rigorously controlled warm room.
We manage the hypothermia risk with cotton blankets and heat shields. Meticulous infection control is paramount.
We transition now to the blistering diseases, a group of disorders where the nursing care closely mirrors that of a severe burn patient.
We'll start with pemphigus vulgaris, the most common EG-mediated autoimmune blistering disease.
So IgG antibodies target the epidermal cell surface, causing acantholysis, that cell separation we talked about, and then blister formation.
The hallmark clinical manifestation often begins with painful oral lesions and erosions. Skin bullae are typically flaccid, they enlarge, and they easily rupture.
Leaving large, painful, eroded areas. The classic diagnostic sign is the Nikolsky sign.
Right, applying minimal pressure to uninvolved skin causes blistering and sloughing.
Complications are devastating: sepsis and massive fluid and electrolyte imbalance from the loss of that protective skin barrier.
Management requires high-dose systemic corticosteroids and often immunosuppressive agents or IVEG to stop the autoimmune process quickly.
Now contrast that with bullous pemphigoid.
Another EG-mediated condition, but it typically affects older adults. Clinically, this is characterized by tense bullae.
They're less likely to rupture.
Exactly. They're found primarily on the flexor surfaces of the arms and trunk, and they usually heal relatively quickly.
We should also briefly note dermatitis herpetiformis, DH.
An intensely pruritic, chronic, blistering disease that has a strong association with gluten sensitivity or celiac disease.
Management requires dapsone, which means screening for G6PD deficiency and a lifelong gluten-free diet.
For all these blistering diseases, the nursing process is highly specialized.
Assessment focuses on monitoring the extent of the disease, checking the oral cavity, which is a high-risk area for pemphigus.
And vigilantly monitoring for infection, noting any malodorous drainage.
Interventions prioritize skin integrity, treating denuded areas like second-degree burns, avoiding friction, and meticulous oral comfort with mouthwashes and anesthetic sprays.
And infection prevention is the #1 priority. It is the leading cause of death in pemphigus.
We have to remember that high-dose corticosteroids can mask the typical signs of infection.
So nurses need to be extra vigilant, relying on vital signs, fluid balance, and lab markers.
Fluid and electrolyte management is intense. The protein and fluid loss through the ruptured bullae is similar to a major burn.
Requiring aggressive IV saline and high-protein, high-calorie nutritional support, often eggnog, milkshakes, or even TPN.
Finally, we must discuss the most severe drug-triggered reactions: toxic epidermal necrolysis, TNN, and Stevens-Johnson syndrome, SJS.
This is a spectrum of acute, life-threatening skin disorders characterized by massive epidermal detachment. 10 is the most severe, with a 25% to 35% mortality rate.
And up to 75% of cases are drug-triggered. Common culprits are specific antibiotics like sulfonamides, anticonvulsants, NSAIDs, and allopurinol.
The complications are rapid and severe: sepsis, multiple organ dysfunction syndrome, and keratoconjunctivitis.
Inflammation of the eye surfaces that can lead to impaired vision or even blindness.
The medical mandate is immediate discontinuation of the implicated drug. These patients require immediate transfer and aggressive management in a regional burn center.
Not a general hospital unit.
No. The care requirements are too similar to a major burn. Treatment involves massive fluid resuscitation and nutritional support. IVG may be used to halt the autoimmune response.
Nursing assessment priorities are focused on the rapid changes, monitoring the extent of epidermal shedding, fever, tachycardia.
And the patient's ability to swallow or speak, as oral lesions can compromise the airway.
Interventions include scrupulous skin care, avoiding any friction when turning, and managing that massive hypothermia risk due to evaporation from the denuded skin.
You have to work quickly during wound care and use warming measures like cotton blankets and heat shields.
Pain management is essential, given on a strict, regular schedule and before painful dressing changes.
And sepsis remains the major cause of death, making strict asepsis during all procedures non-negotiable. Eyes must be inspected daily and lubricated frequently to prevent vision loss.
Our final major focus is skin oncology. The leading preventable risk factor for all skin cancers is, without question, UV radiation exposure.
Both from the sun and tanning booths. The damage is cumulative, often peaking by age 18, but the cancer can manifest 20 to 50 years later.
We monitor benign and premalignant lesions closely. The critical one is actinic keratosis.
These are those rough, scaly lesions in sun-exposed areas that are classified as premalignant because of their high risk of transforming into squamous cell carcinoma.
Moving to malignancy, basal cell carcinoma, BCC, is the most prevalent, representing 80% of all skin cancers.
It grows slowly and rarely metastasizes. It typically appears as a small, waxy nodule with rolled, translucent, pearly borders.
Often showing those tiny telangiectatic vessels.
Right. Squamous cell carcinoma, SCC, is the second most common, often arising from an actinic keratosis. This one is more dangerous.
It's invasive and it metastasizes in 4% to 8% of cases. It presents as a rough, thickened, scaly tumor.
The surgical goal for non-melanoma skin cancers is complete eradication. The gold standard is Mohs micrographic surgery.
Mohs is critical for cosmetically sensitive areas like the eyes, nose, or lips.
Because it's the most tissue-sparing method, and it offers the highest cure rate. It works by removing the tumor layer by layer and immediately analyzing the margins under a microscope until only clear tissue remains.
That precision ensures minimal healthy tissue is removed.
Other options include electrosurgery and curettage, where the tumor is scraped out and residual cells are destroyed by electrodesiccation, or cryosurgery using liquid nitrogen.
So nursing management relies heavily on prevention. Minimize sun exposure between 10 a.m. and 4 p.m., wear protective clothing, and use broad-spectrum sunscreen.
SPF 15 or higher, and reapply it every 2 hours.
Now let's discuss melanoma, the cancerous neoplasm of melanocytes. Prognosis depends entirely on early detection.
Which makes patient education absolutely critical. Nurses have to teach patients the ABCDEs of moles for their monthly self-exams.
A. Asymmetry.
B. Irregular border.
T. Variegated color.
Shades of red, white, or blue. Shades of blue are the most ominous.
D. Diameter greater than 6 millimeter.
And E. Evolving. Good. Any change in size, shape, color, or elevation.
Now, while the ABCDEs tell us what to look for, the most crucial clinical insight which dictates prognosis is the Breslow depth.
Absolutely. Melanoma grows in two phases. The early radial phase, which is horizontal spread, and the later vertical phase, where the tumor grows downward into the dermis.
The Breslow depth measures how far that vertical phase has penetrated.
And this depth is the strongest predictor of metastatic potential and overall survival. It's the most important staging criterion.
For advanced or metastatic melanoma, treatment has been revolutionized by targeted therapy.
If the tumor is tested and found to be BRAF positive, which is about half of melanomas, we can use oral BRAF inhibitors combined with MEK inhibitors.
These agents specifically block the cancer growth pathways driven by that mutation.
And for tumors that are BRAF negative, we use checkpoint inhibitors like pembrolizumab or nivolumab.
These are immunotherapy agents.
Right. Conceptually, they prevent cancer cells from flipping the off switch on the patient's T cells, thereby unleashing the immune system to attack the cancer.
Finally, we should acknowledge Kaposi sarcoma, KS.
A malignancy of endothelial cells, often appearing as reddish-purple to dark blue lesions. The AIDS-related or epidemic form is the most aggressive, involving both skin lesions and rapid systemic dissemination. We can wrap up with surgical interventions, distinguishing between cosmetic procedures and reconstructive procedures.
Cosmetic procedures correct non-life-threatening defects and usually aren't covered by insurance. Reconstructive procedures correct surgical or congenital defects and often are.
Wound coverage often uses grafts or flaps. A skin graft is detached skin autograft from self, homograft, or xenograft transferred to a new site.
But a flap is superior.
Because it remains attached at one end or its pedicle, and it retains its blood supply. Flaps provide bulk and a much better color and texture match.
The most complex is the free flap,
Which is completely severed from its origin and requires microvascular anastomosis to restore blood supply at the new site.
For skin rejuvenation, dermabrasion is used.
A sanding action to remove the epidermis and superficial dermis. If a patient has a history of herpes simplex, prophylactic antivirals are mandatory to prevent reactivation.
And laser treatment uses amplified light energy to precisely vaporize tissue.
A key clinical advantage of lasers is that they seal small blood and lymphatic vessels as they work, making them particularly safe for patients with bleeding disorders.
Since most of these surgeries are outpatient, nursing management really centers on post-operative teaching.
This means providing meticulous, clear instructions, both written and verbal on dressing changes, managing pain, minimizing bleeding, and avoiding friction.
And if the procedure is near the mouth, we teach patients to limit talking and facial movement and to avoid any dental work until they're fully healed.
Exactly, to prevent disruption of the sutures or grafts.
What an immense journey through the anatomy, pathology, and protocols of dermatologic nursing.
We covered so much. We navigated the crucial concepts of skin pH, the dangers of adrenal suppression from high-potency steroids, and the life-saving importance of the 5 rules of wound care.
We synthesized the complexities of pressure injury staging, differentiating a stage 1 from a dangerous DTPI, and emphasized the systemic crises inherent in autoimmune blistering diseases like pemphigus.
And the urgency of recognizing SJS and TIN as immediate burn center referrals.
And we closed with skin oncology, reinforcing the ABCDEs for melanoma identification, but adding that crucial clinical context that Breslow depth, the extent of vertical penetration, is the true determinant of prognosis.
Which drives modern treatment with targeted BRAF inhibitors and checkpoint inhibitors.
The essential nursing takeaway seems to be that the skin is demanding, it requires specialized assessment, and it demands detailed, meticulous patient education.
It does. Whether you're teaching a family member how to use the Braden scale, explaining the drug interactions to an acne patient on isotretinoin, or reviewing the ABCDEs, that education is the ultimate intervention for long-term health and preventing recurrence in this population.
A profound point. Thank you for joining us for this deep dive into the management of dermatologic disorders.
Thank you. Be well and keep applying that knowledge.